Awesome. All right, so we are going to give everyone a couple of minutes just to log on. And while everyone's getting logged on, go ahead and do some housekeeping. And don't worry, I will repeat this information at the end of the webinar. But thank you all, first of all, for joining us this evening. My name is Brooke McGivern. I'm a speech pathologist and the Director of Marketing and Communication here at Tim's Medical. A couple of housekeeping items regarding this webinar. If you are wanting ASHA CEUs for this presentation, we ask that you stay for the entirety of the webinar and then complete a quick survey at the end. I'll put it in the chat, but you'll also receive the link for the survey from Zoom emails. But if you're not signed up for Zoom emails, don't worry, just feel free to send me an email at tims-univ@tims.com and I can send you the link. That survey will be open from tonight until next Wednesday, at which point we will close it and submit for ASHA CEUs. If you are wanting a certificate of completion for this webinar, feel free to send us an email at tims-univ@tims.com and we'll create a custom certificate. We don't automatically send them out, but if you want one, we're happy to create one for you if you send us an email. And this webinar will be recorded and uploaded to our website within 7 business days. So if you are, miss any information or want to go back and listen, no worries, you will be able to do so on our webinar. And with that, I'm going to go ahead and pass it over to Rachel, who is our keynote speaker for this evening. Rachel?
Hi guys, thank you so much for having me, Brooke and Tim's Medical. I'm very excited about this. This is my baby, this project, but I hope to share it with you guys and get this resource out. I'm gonna go ahead and share my page. And excuse me if I have any little cough or anything. I am dealing with a little bit of a cold right now. Okay, everything look good on your end. Let me make this screen bigger. Okay, so my presentation is only about 45 minutes, so it will leave us some good time for questions. I like to design it that way because I feel like I want this to be interactive. I know that Brooke will be checking the chat, but I think we should save all the questions for the end just to get the flow going, and then we'll take a break and answer everything you guys have. So this specifically, let me double check the chat, make sure nothing popped in. Perfect for CEUs. So this is speech language pathologist lead role in the multidisciplinary tracheostomy team. Variations of this has been presented. However, this is the first time this is being presented other than at a national variation of the live current retrospective and prospective data that we collected based on this project. My name is Rachael Silveira and I work at Jackson Memorial Hospital, but all of this was conducted at my HCA facility previously. So a little bit about me, if you haven't already known who I am or got the information from the lecture bio. I've been a therapist for 8 years now, diverse training. So I've done everything from strokes to burn to neuro, but found my love in like complex respiratory compromise, meaning trachs and vents. So I currently work at a 1,500 bed facility, soon to be 1,700 bed. And I do a lot of transplant and respiratory compromise. Guest lectured at several conferences. I take a lot of mentors and students. So I really like to emphasize that whatever we're learning now in our current practice, it's so important to give back to the new and to the future of our profession, because I will say this, and I will probably die on this hill saying it, as I didn't learn any of this in grad school. So if you're a new grad on here trying to learn, this took years, but get yourself a mentor that can teach you this, because this was not taught in grad school. I pride myself in actively participating in research to raise awareness for our speech language pathologist role within this population, because we find our role is kind of mushy and washed in there, and they don't understand what we do other than like help a patient speak or do a dysphagia eval. But there's a lot of things that we can do specifically for trach and vent population, and also helping healthcare providers, patients, and caregivers improve their confidence going home with the patient like this or treating a patient like this in the hospital. We are the experts in this field. And then finally, what you'll be hearing about tonight is if you are interested in spearheading an initiative in your own facility, this is based on data from my current and my previous healthcare systems that allowed for reduced length of stay, reduced adverse events, and improved quality of life, which is our main goal for everything. So my disclosures right now are that this data was presented and supported by my previous institution, HCA Florida, Kendall Hospital. I received an annual salary. The doctors that were on this project, Dr. Jordan, Dr. Wilson, Dr. Morejon, Ms. Puebla, and Mr. Luque, all received salaries as part of this project, and they have permission to present on their absence. I have no other financial disclosures relevant to this exact presentation. However, I am getting a stipend through Tim's Medical, and I own a tracheostomy education company that provides lectures and resources, which I'll give you guys some information about at the end. So those are my disclosures associated with my company. So what are we going to learn today? We came here to learn the importance of a tracheostomy team with our emphasis on a speech language pathologist role. There's a lot of research out there that shows intensivists, respiratory therapists, dietitians, and other participants being the lead role, but there lacks and there's a gap in literature about our focus. So that's what I wanted to take away from tonight. We'll describe and design tracheostomy teams with appropriate phases and components. So we'll add different people. We'll talk about what you need to help it grow, thrive, and survive to sustain optimal growth and sustainability. So it's one thing to create a team, it's another thing to watch it grow, and it's another thing to sustain it and actually look back at it and pull retrospective data and say, hey, this actually worked. And then finally, we'll interpret statistical significance based on the retrospective nature of the study associated to outcome measures. So I think this is the wow factor of it is it's one thing to do a project, it's one thing to see it work, and it's one thing to have actual tangible statistical significant data associated to speech that you can take and give to your director, you can take and give to your team members and show this is the importance of our role and it's statistically significant. So no one can tell you, oh, well, that study, da, da, da. This is statistically significant and you can use this tomorrow in your hospital setting or wherever you work. So let's just do like a real quick recap. What is the purpose of a team? Kind of in its own wording, a tracheostomy team, you could imagine would enhance consistency of care through the development and implementation of an interprofessional protocol. The team would allow for more efficient and effective communication and decision-making processes. And this was provided in an older study over 10 years ago by Mitchell et al. However, the introduction of tracheostomy teams in multiple clinical settings are aimed at improving both patient and hospital outcomes. So I think it's very important for us as speech language pathologists to understand both type of outcomes. So when we're talking to different providers in our hospital, whether it's a doctor versus a administrator, they have different goals and different mindsets, and that will really help shape your buy-in associated to who's going to participate and if it's actually going to get off the ground. So when you're looking at hospital-based outcomes, hospitals are looking for decreased length of stay. They're looking for reduce of incidence of readmission or a patient coming back. They're looking for improved patient outcomes and quality of life, either in the form of survey or word of mouth. And they're also looking at reducing any adverse event that would happen in that stay associated to the tracheostomy. And that can include infections, dislodgements, or even death. Our SLP-based outcomes is what we're focused on. And I think a lot of the times we get caught up on our goals, our goals, but really we have to shift the focus on what's going to get the buy-in to create this team, and then we can target our goals within that. So our speech goals are going to be ensuring that every patient that we work with a tracheostomy has the ability to effectively communicate, right, their wants and needs. It's actually a joint commission requirement that if they were to walk into any patient's room, they're going to ask you, have this patient communicate with you. Communication board, head nod, yes or no, verbal, nonverbal, AAC device. And a lot of the time, these trach patients get stuck in this limbo where they don't have a verbal communication source, and maybe they're cognitively impaired. So we're trying to deliver some sort of mode of communication for them, whether it's a communication board, a head nod system, or simply putting a speaking valve on. We also want to work on our role with all these patients and being involved in the consult from the get-go. A lot of the times, and I'm sure you're nodding your head behind the screen here, we get the consult way too late. We see them when they're out the door, they're already on trach collar, and they're getting shipped off to an LTAC. Well, we could have worked with them when they were on the vent, put a speaking valve on and actually maybe do a FEES or a modified barium swallow study weeks prior. We also want to streamline the progression of a trach. So it's not just trach and discharge them. Are we going to optimize the size of the trach? Are we going to make it smaller? Are we going to advocate to get it removed? Are we going to talk about capping and decannulation and ensuring that these procedures are done in a timely manner? And then finally, we're going to address barriers that can happen throughout the hospital and how they're resolved by just kind of creating that multidisciplinary aspect. A trach cannot be managed by one single person. It is a multidisciplinary objective, a multidisciplinary plan. We cannot do it alone, and the surgeons can't do it alone. And anyone who thinks they can do it alone is severely wrong because it requires the hands of different professionals. We can't decannulate, right? We can't put a trach in. but also our counterparts, our doctors cannot do a dysphagia eval with the fees and do not typically know how to do an inline speaking valve. Respiratory therapists may be the leaders in the suctioning and the cleaning. Your nursing may be the leaders in that as well. So it takes a village to take care of this patient population. So why are we developing this team? I don't know if you know this, but tracheostomies are one of the most frequent procedures performed in the ICU other than intubation. However, there's little consensus in the post-operative management of this. So I challenge you tomorrow to go to your facility and ask a surgeon or a doctor on the floor in ICU asking, what's your plan with this trach? And 9 out of 10 times they're going to say, I didn't place it. I'm not sure. Let's call the team who placed it. Or, oh, well, they're fine. They're mechanically ventilated. We're just going to wean the vent and see how they do. No, I want to know what that person's goal is at the end. Are we trying to downsize? Are we trying to decannulate? Sometimes we can't know, but it's always good to have that prospective concept of we want to assume that our patient's not going to be vented for the rest of their life. And I think that's what we're special we bring to the table is that we see that. We see that they can eat, we see that they can communicate, and we strive for that. Where a lot of the physicians are tunnel vision and they only focus on they're vented, they're breathing, and that's all I care about right now. There's a lack of standardization with this population, right? And it can result in both short and long-term complications. People aren't managing it. So it's a trach them and forget about them concept. And it's usually the surgical teams that place it that do not follow the patient. It's taken me a long time to come to grips with why they don't follow the patient. And it's because their volume is too large. Do I think that's appropriate excuse? No, because we have large volumes too. But surgically on the totem pole, a tracheostomy is a very, very low billable procedure and a quite frankly safe and low incidence rate procedure that it's not comparable to a liver transplant or a esophageal resection or a cancer treatment. That person needs more ongoing surgical management. It's an airway source, the patient's ventilated, and they just don't follow the patient. They get dropped off their list and they will tell you, oh, we're not following that patient anymore. Please reconsult me when needed. Well, what is when needed, right? When needed is to downsize, to cap, to decannulate, to monitor. So we need them on the case and they need us. Some of these complications can include infection, hemorrhages, dislodgements, tube obstructions. Our specialty, impaired communication and swallowing, which is why we should be flagged on all these patients, pneumonia, tracheal stenosis, and then the worst one being death. And then finally, having inconsistencies in care can be from a variety of follow-up. So they leave the ICU prematurely maybe, or even just on time. They transfer out of the ICU and they have a lack of their processes and protocols in place. And maybe that floor nurse is not as familiar with the trach as that ICU nurse was. So what are some of these inconsistencies in care that we speak about? Well, the choice and sizing of a tube is a huge one. I know you probably have a lot of hospitals that put 8s in patients and some only do 6s. When is the initial trach tube changed or exchanged, the timing of it? Who manages the trach cuff-wise? So as soon as they're off the vent, is someone coming to deflate the cuff after they're off the vent, or is it remaining inflated? Who is decannulating and capping? Who is putting the consults for communication and swallowing? And what's the timing of that, right? Is the concept in your ICU, oh, let's wait till they're off the vent to consult speech? Or are we getting that consult as soon as they're trached? Who is called in an emergency? This was a huge facility-wide improvement project in my facility that it was initially called a rapid, right, when something happened, but later changed to a code blue because in the event of an airway emergency, you need someone that can intubate from above or reinsert a trach. And in a rapid, those personnel do not arrive. So that's a concept that creates a lot of inconsistencies in care is who's going to show up when something goes wrong. Care and cleaning, and then patient education. So some specific like citations in that same article from Mitchell et al. In 2003, he noted that for follow-up care, he did a focus group, and on those members of the focus group, they said that after the development of a tracheostomy team, it eliminated the need for individual chase-up or calling of different personnel and different specialties about management decisions. So this happens in my facility with 7 different service lines, right? ENTs placing trachs, cardiac is placing trachs, transplants placing trachs, trauma, pulmonary, OMFS. Who do we call? Whose trach is this? You can assume the type of patient it is if they're in the medical ICU on a pulmonary floor, maybe pulmonary did it, but sometimes you don't know. It could have been a trauma that came in that went into respiratory distress and now is on a different floor. So who do I call for follow-up management? So creating this team kind of eliminates that questionable experience and allows for more streamlined care for you and for them. Also, that transfer out of ICU concept, I bring that up because if you have an ICU to a step down to a telemetry floor, you know that the experience of those nurses is going to vary. And it's nothing wrong with the nurses, just that they're not exposed to those trach patients on the regular. So insufficient skills and experience on a floor can lead to suboptimal care with these patients, right? Like, oh, he's fine. Like RT will do it. Well, really, it might have been the nurse's objective to clean the wound or clean the stoma or put a new gauze. So in a study back in 2007 by Schleck et al., he reported that management of trachs in non-ICU rooms had higher odds of death than those who were decannulated in the ICU. And their proposed rationale for that was poor tracheostomy care on the floor by step-down or unexperienced nurses. So this is not anything new. There's a lot of literary support that shows that multidisciplinary tracheostomy teams can improve patient outcomes, including from a communication standpoint, from a dysphagia standpoint, from reducing adverse events and decreasing length of stay. So if we break it up into different categories, we have communication, for example. A lot of this literature falls right below that 10-year mark. So that's why we were very, very excited to get something published out in 2024 that was more current literature. Because as you know, what you're doing right now sometimes takes anywhere from, I think it's 10 to 17 years, correct me if I'm wrong, Brooke, to get like actually out and be utilized in the community. So for example, what Demenstrol in 2011 produced is kind of what's occurring right now, right? A significant increase in the number of patients who received a speaking valve went from 19% to 64. That's a huge jump. SPED at Harding, that's right around like 11 years right there, reports multidisciplinary care led to a faster decannulation and improved speaking valve use. So this isn't anything new. This has been researched and studied, but has it been implemented in various facilities? And has a speech language pathologist been very well versed and incorporated in this care? If we look at safety and decannulation, Aurora et al. In 2008 showed that decannulation decreased significantly from 21 days to 5.4 days after implementing a team. That's 15 days less of that patient having a tracheostomy tube in their neck. That's essentially 2 weeks, right? ICU time, that's huge. That's, that's reducing risk of infection. That's need for a nurse to not clean a stoma or an airway. That's need for not additional oxygen, right? You're letting the patient rid themselves of an artificial airway. Also, Demenstrol in 2011 noted a significant downward trend in the mean days to downsizing and decannulating. So I guess it depends on your facility. If there are serial downsizers before they decannulate, some facilities just go straight to capping and decannulation. We've tried to adopt actually creating a smaller size trach before doing all this. It does show in the literature that it can affect adverse events, right? If you move too quickly, something can happen in between. So we do like to take that stepwise approach, but some facilities don't. And you can see in this 2011 study, it dropped significantly. They went from 26 to 9.4 days for downsizing and 50 to 28 days after decannulation. And then finally, length of stay. This is your bread and butter. This is what's going to get your hospitalist, your intensivist, and your administration on board. They want to know that your role in this project, or even just this project in general, like let's remove ourselves from the role, will help save the hospital dollars. It's bottom dollar. The days less that patient can stay there speaks volumes to them. So if we can show that our role contributes to a shorter length of stay, they're going to love it, right? So Cameron et al. Found the length of stay went from 60 to 41 days, and the length of decannulation went from 22 to 16. Studies attest a decrease in number of ICU days, possibly due to the dedicated tracheostomy coordinator identifying eligible patients. I found that interesting because we kind of are those people, right? We are the dedicated coordinators in a sense because we're already evaluating these patients for dysphagia and swallowing. So we're identifying who can be ready to be capped and downsized and decannulated probably quite quicker than a hospitalist or an intensivist could. And then obviously identifying who can go from intubated to trached is a different story. But that also there's literature showing early versus late traching has some significant data that if you can trach someone sooner, they have a better outcome than being intubated longer. So drum roll, what is our role, right? Highlighting our importance. That's kind of what I want to raise awareness about is we know that we're underutilized, right? Davis et al. Wrote a wonderful, wonderful paper in 2021 about how speech services are underutilized in tracheostomy rehabilitation. And that's like a staple paper for me, and it's very current. So if you haven't read that, check it out. When you rely on other services to consult you, we're involved less frequently, right? And our participation isn't integrated into the standardized process because multifactorial. They don't know what we can do. They don't know our role, and it slips their mind. At the end of the day, this is not an important thing for them as bad as it sounds, but we can make it important, right? And we can also take it off their plate by simply just having them put us on a post-op order set and never thinking about it again. So from our latest research in 2024, we saw that the complex relationship between respiration, swallowing, and communication dictated that speech pathologists play an integral role in the part of the multidisciplinary team. And don't forget this part, the management of the tracheostomy. So we're not just there to do speech and swallow, we're there to help with management and progression. So then what do we provide? What kind of roles? What can we do? We can provide services to both ventilated and non-ventilated patients. And that's the big buzz, right? We wait until we get a consult when we're off the vent, but they don't understand our role on a ventilator. Passing Muir valve has dedicated years to conducting research that using a speaking valve can help during weaning processes. So why is it that PT and OT get consulted on intubated patients and on trach patients the minute they get this artificial airway, but we have to wait, right? Yes, they're passively ranging motion them even when they're sedated, and we have a little bit more restrictions when patients are sedated. We can't do as much, but if they're able to get that consult and get early intervention, then we should be able to also. So we can do fees, we can do MBS. My mentor, Eric Blicker, kind of showed us how we can assess the upper airway and assess patency and secretion management. So now you'll catch me just running down the halls doing fees on patients with trachs just to see what's going on in there, right? Oh, they're coughing, they have too much secretions, they're aspirating, they're not ready for a fees. Well, let's just do one because I want to know why they're coughing. I want to know why they have so much secretions. Maybe there's something we can do. Maybe the NG tube is stenting open the UES and creating more reflux. So there's a lot of things that we can assess by using a fees in a trach population. That's not only dysphagia and speech related. We're looking at airway patency. Let's put the valve on. Let's take the valve off. Is there any improvement with secretion? Is the cough stronger? We can use speaking valves. We can refer for downsizing, for capping, for decannulation, and we can optimize their care. I always write that in my notes. Speech is present to follow and optimize the progression of care for this patient. We can provide patient and caregiver education. A huge, huge, huge endeavor in my facility. It's large, but the turnover is really large, and the nurses just don't feel comfortable with these patients, as well as the caregivers. The first question I usually get when I go into a room with a trach patient is when can they eat, when can they talk, and when is this coming out? So that's what we target. We have a brochure and we go over, this is a trach, this is your airway, this is what he's doing right now. It's ventilating him or her. We're going to try to do a swallow study. We're going to try to do a speaking valve when the timing is a little bit more appropriate and the patient's participating. But we're also going to stay with you through this journey to trial a speaking valve, to try a downsize, to see how they do in capping and get you across the finish line and get you to the decannulation, which is how they were before they got here, right? We want them to leave better than we received them, right? And then finally, you can advocate for your patient and you can facilitate communication and collaboration amongst our team members. Oh, I think I'm missing a slide. Okay, that's all right. So what are our various trach team designs, right? Who is involved? And this is just from my literary review. There's one model called the TRAMS, and it's including a consultative team of physicians, a nurse, a respiratory therapist, and an SLP. So that's good. We're on that team. There's another format out of John Hopkins down below. It's a physician, a nurse practitioner, a speech language pathologist, a respiratory therapist. They also added a nurse, clinic nurse, and a support staff. And then I've also seen dietitians on these teams before too. So what was our team? Our team was a little bit more unique because it was a trauma facility that trached very early and had a high volume of trachs. So we decided that we were going to take an approach that did a core and a support staff type of approach. And what that means is just that not everyone had to be present all the time, but they were available when needed. So our core members were our surgeons. So we had a trauma and a surgical critical care surgeon. And then we also had a general surgeon. So what that meant was all the traumas and the real severe ones were one surgeon, and then your medical ICUs was another surgeon. So I liked having two because you never know what you're going to get in the cookie jar. You didn't know what kind of trach you were going to get that day. So we had two champions that I could bounce ideas off of. We had a PA instead of an NP, but that's like your person putting your orders. What was unique to our program is we had a surgical critical care fellow, Nicole Jordan, who's on this study. So what we did is we implemented in this project that every year a new fellow was assigned to the project. So if we went back almost 3 years, the first fellow kind of initiated this, helped with the team, and then once her fellowship or his fellowship year ended, the next fellow that came on board was kind of given this as a gift with a bow wrapped on it and said, hey, we have a tracheostomy team at our facility, in the nicest way possible, like you're gonna help run it, and you're gonna be working hand in hand with speech, respiratory therapists, and you're attending to kind of optimize these patients. And we never had any problems in the 3 years that we did it. I don't know if it's still happening, but you may hit some resistance. I don't know how many fellows you have at your facility. We had 3, so we had a choosing of who really wanted to do it out of the 3. You may hit some resistance, but I think it was such a unique perspective because they're still learning. They're getting great guidance from their attendings, and they're also very willing to participate versus an attending who might be really busy and kind of hands off. This person was there, data collecting, putting orders, and really being involved in the process. We had a speech language pathologist, a manager, and respiratory therapist. We had both. So our respiratory therapist was on the floor doing inlines with us and rounding, and then the manager was used for like protocol development, kind of spearheading specific things related to respiratory. And then when we hit that hiccup of ORT is not available to do an inline, we had our manager on speed dial to ensure that that patient had got an inline placed that same day and we had no delays. Our rounding team, so remember, not everyone has to be present all the time. We rounded twice a week. I rounded every day with them, but the big meetings were on Tuesdays and Thursdays for like about 30 minutes after rounds. We had our critical care provider, our speech language pathologist, and our respiratory therapist. At my facility, respiratory did everything trach related, vent weaning, care and cleaning, exchanges with a surgeon present, and then a facilitated and decannulation process with a surgeon present. I know in some facilities it's nursing. I'm in one right now that does that. It creates a lot of issues because I don't think they're as equipped as RTs are, but you can still work with it. I would just say switch out your RT for a charge nurse or a champion nurse that's going to be able to help other nurses on the floor. Our support staff was a trauma educator. She was a nurse, and she actually educated everyone. She was our champion, so she did like in-services. We had a pulmonologist for some difficult airways. We didn't have ENT at this facility, so that was our difficult airway consultative service. Departmental directors are important because they can streamline your protocols, your standard operating plans, things that are at a higher systems level that we're not included in as much, they can do for you. You definitely want to start collecting data and have a statistician or find out in your facility if someone can help you comb through data. Don't get yourself stuck in this position where you start going through data and you weren't approved to. It can get you in trouble, but also it's a lot of data and you need help. You want a research coordinator and an informatics specialist. Didn't even know this existed, but this is your person who's going to make your power plans, your order sets, and create anything you need into your EMR system. So progression and phases. It's not just let's get everyone on board and hit the ground running and go 0 to 100. We had to kind of break this up into phases. And if you can see from my article, we did 3 phases. So we had like a creation and buy-in phase. We had an implementation of protocols and procedures phase, and then we had an adherence phase. So adherence was just kind of data collecting. It's those last 2 kind of combined into one. And I think the system worked pretty well because from new experience at a new facility, I've had some professionals want to go 0 to 100, and it has actually created like hiccups in the system and like fall throughs where we're trying to do too much at once and we don't have the buy-in, right? Because that was a 450 bed hospital now to a 1500. You have to kind of start slow and really make sure your key players are on board before attacking and adding so much to their plate. You want to find key members, you want to review guidelines and benchmarks, creating a schedule of when your meetings are going to be. I think a really big thing is create a mission statement and a vision and a goal for your team, right? Because people buy into that. They want to know what your vision is. They want to know what your goal is for this project other than let's improve patient care. Well, that's everyone's goal, right? What we really specifically want to do is provide care and assistance to tracheostomy patients while optimizing a standardization of care throughout the facility, right? From start to finish. We want to create protocols. Does your facility, think right now, does your facility have an inline speaking valve protocol? Does your facility have a capping protocol? Does your facility have any type of guidelines or flowcharts that can direct them in a downsizing process, when and why we downsize. And then finally, decannulation. Do we have any sort of protocol of when a patient is ready for a decannulation, and how do we go about it? Who does it? How long do we wait until we do it? All of these things, you have to create these things. So you can author flow sheets and processes and protocols. There's not a lot of it on the internet, right? So it actually requires a bit of creativity. And that's why I say find your key members, find your people, because they're going to sit with you and help you develop this. I think it's sometimes a little bit easier when you have nothing, because then you have the liberty and the autonomy to make what you want. Whereas if you're coming from a facility that already has a lot in place and it's not working, you have to restructure it. And that's where you hit the hiccups. Like, oh, well, we have a protocol. Well, it obviously hasn't been working, right? So you hit that. We've always been doing it like that. So I kind of like starting from a blank slate. You want to schedule in services, create handouts, brochures, anything that's necessary for your facility, what you think is going to get across. A badge buddy for nurses, a brochure for family members, an in-service that's like a PowerPoint, whatever you think is going to work, a lunch and learn. And then finally, you want to data collect. I did this quite early because I knew I wanted to actually assess data and improvement. But if you wait till the end, that's fine too. It's just going to be a lot more data. But every time you get a trach, jot down the MRN or the FIN number, obviously get the necessary approval, and then keep track of it. And that kind of like opens your eyes to like, wow, that took 27 days for us to get consulted, or wow, that took 32 days of patient getting cannulated. I mean, you can kind of go back and see like, where did the problem happen? But it's very hard to conceptualize that without seeing it on a piece of paper and knowing the dates and the times and how long it actually took. So this is the components we used for our trach team. We did multidisciplinary rounds, weekly rounds, and monthly meetings. We did educational in-services, badge buddies, and speaking valves. We did protocols, including creation inlines, downsizing, capping, and decannulation protocols. We created a tracheostomy post-op order set to capture all of our trach patients. And then very unique to our facility was a tracheostomy progress tracker sign on the door, which is actually proprietary information or of theirs. I couldn't share it with you, unfortunately, guys, but it is a beautiful rainbow arrow that I created from green to blue, red to blue, red meaning the first day the trach was placed, and then when the sutures were removed, when speech was consult, when do we put a speaking valve, how are the secretion managements, when do we downsize, when do we cap, and then blue was the decannulation. So it's just a nice flow sheet, kind of similar to PICO scores and a turn schedule, colorful, bright on a patient's door. So it's very useful during rounding because you can just point to a color and know what zone you're in and say, oh, the patient's in a blue zone, they're getting ready to decannulate. Or, oh no, they're in a yellow zone, we're still working on downsizing and capping. It's HIPAA compliant, there's no names or information on it, it's simply attached to a room number, and that's it. So we're doing good on time, good. So basically, let's dive into our components that are going to be SLP driven. What can you take to your facility tomorrow and start working on? So the biggest thing, if you can't take anything away from this, like you're not able to do inlines or fees or decannulate, I would say get a post-op order set started, because you don't know what you're missing until you know what you're missing. You don't know how many patients you're not seeing until you actually see the volume of trachs being produced in your facility. So get with a provider, see how you can run ICD codes or run procedure codes and see how many trachs are being done on a monthly basis, for example. And then you're going to go and pull that data and then see how many of those were actually consulted for speech. That will give you a good percentage, right? 40%, 30%. We started somewhere around in the 20s at my last facility and went all the way up to the 90s. In my facility now, we were about 40%, and now we're in the 60s. So it takes a bit of time to build up that volume because people have to use the order set. Speaking valve use, using a standardized capping and decannulation protocol, using fees for decannulation, and then continued education. So if we dive into the first thing, which is an order set, this is not anything new. A trach post-op order set has been utilized in a lot of literature, but recommending it that it has a preset check speech console is super important. They've been shown to reduce length of stay, medical errors, and mortality because we're on the case and we're kind of looking at these things during our normal therapy. We are looking for downsizing, we're looking for infection, we're looking for secretions, we're looking at stuff that is going to raise a flag that we're going to write a note about and kind of alarm someone about. In a Ma et al. Study in 2017, utilizing a bundle, they called it a bundle, which is the same thing as an order set or a power plan. They said that the number of speech language pathology consults increased compared to baseline after using a post tracheostomy care bundle. It was statistically significant. They said the time to their speech consults significantly decreased post tracheostomy care bundle compared to the baseline. They also found, kind of completely outside of this, but you're going to start seeing links in your data, that with this bundle, they also found a decrease in decannulation, sorry, an increase in decannulation of patients and an increase in toleration of oral diet after they implemented an automatic SLP consult. So the goal was just to get all these trach patients on the caseload, right? But as they started combing through their data, they noticed, well, hey, people are actually getting decannulated faster. People are actually eating sooner. Like, this is a really good thing. And then using a speaking valve. So I came from a facility that had both purple and green down there. Now we only have green because it can be used on both. But I do feel for these facilities and these patients who only are able to use a speaking valve off the vent. It's such a great disservice to these patients because we can do so much with them on the vent. And then you think about your quads and your spinal cord injuries and patients who are chronic vent dependent. They're never going to get the ability to communicate with the speaking valve or even try to swallow and eat with speaking valve because your facility doesn't allow it. Granted, a lot of these patients can eat on a vent without a speaking valve, but the voice is a huge thing, right? It's a viable way to communicate. So Bloomfield in 2011 suggested that tracheostomy speaking valves can positively, in fact, impact swallowing function, which we know. And current empirical data shows that the use of a speaking valve in line with mechanical ventilation promotes improved ventilation. And that was Set et al. In 2016. And then Carmona in 2015 also saw faster weaning. So that's a kind of a little bit of a tidbit I tell my intensivists is, hey, this can help you. Like, you want to get them off the vent. Let me get in there and try. Every time we deflate the cuff and put this valve on, we're actually allowing the patient to work. We're actually pushing the limit. It's just like EMST. We're strengthening the lungs. Allow us to do this. It's controlled. We're not going to harm the patient, but they get so caught up on the deflation, kind of stunting the patient's progress, but it doesn't. We're not altering anything other than creating a patent airway and allowing the patient to work. So then using a standardized trachea capping and decannulation protocol. You can see here, we have two studies about clinical stability and tolerating a speaking valve that led to when we're going to cap them and decannulate them. And then to the right, the Vincia Pandian one, which is an amazing article, and we're actually using the same concept based on, they have a 12 and a 24-hour approach. We're doing a 24 and 48-hour, but it's nice because it allows other providers, an SLP, an RN, an RT, or an MD, to kind of deem that patient appropriate to start trials. So you don't have to wait for one specific person. It kind of encompasses that multidisciplinary concept. So the one from China on the left basically was looking at 115 patients that were evaluated for decannulation candidacy, and 56 of the 57 patients were decannulated successfully utilizing this algorithm. The clinical stability of the patient was assessed 48 hours off the vent. So, like, right when they're off the vent, we're already kind of thinking what's happening next. They needed to be hemodynamically stable with no organ failure. They couldn't be suctioned more than once every 4 hours, and they needed to expectorate their secretions orally. And then they needed a PCCO2 level of less than 60. So they were running ABGs on these patients. Patients who could not tolerate a speaking valve or any upper airway concerns were then given endoscopy to assess. So that ENT or doctor was doing an endoscopy procedure. All the patients who did not need endoscopy were successfully decannulated. If we look at the Pandian et al. One, that one was a high screening tool with high sensitivity and kind of promoted communication and standardization of practice through multidisciplinary, like we mentioned. They had 61 patients, a little bit of a smaller sample size, that were enrolled. 57 were proceeded to capping and decannulation within the protocol. 54 of those 57 got capped, and 50 of the 54 got decannulated. The 3 remaining had difficult airways and did not proceed with capping or decannulation. And I don't know specifically if they got scoped or not, but they just did not pass that capping trial. So what this screener tells us is that this tool has a 90% sensitivity for identifying which patients are decannulatable and 100% specificity of who could not be decannulated. So there's a positive predictive factor of 100% and a negative predictive factor of 16.7. So it has pretty good ratings for our tool to be utilized effectively to identify who's ready. This one is something so new to me in the last 2 years, but I think it's been such an invaluable tool. Eric Blicker trained me on how to utilize us fees to help with the decannulation process. So we're willy-nilly going around saying this patient's ready for decannulation. Sometimes doctors are like, yeah, they look good. They've been wearing the speaking valve. They look fine. But we forget that we need to also really like look at the anatomy and assess the airway to be 100% sure we're not missing anything, right? So this uses a standardized endoscopy swallowing evaluation in the setting for decannulation in neuro patients on the right, and on the left, it was done on a different type of population. So basically, the one on the left in 2020 by Yosef was done on 112 patients, and 18 were determined to be decannulation candidates just by looking at them at bedside, right? The endoscopy was then used to assess the larynx, the subglottis, and the trachea on 59 of those other candidates, right? And then 13 of them then for changed to decannulation candidates after the exam. So we missed 13 patients, right? Because they didn't get their airway checked, right? Either they had secretions or we were like, oh, they sound icky, we're not ready. But then we looked in their airway and we said, oh, they are ready. Like, this is wonderful. We're able to decannulate them. So it showed a 72% increase in the number of decannulation patients when endoscopy was used and added to the bedside, right? The findings are in line with other studies by Wernicke and with Mule that finding that 82% of patients are successfully decannulated when you implement a scope exam in conjunction with the bedside. So we're not removing our clinical observations, we're just adding an extra layer of evidence-based practice. And then Mule to the right, wonderful study. It looks at secretion, spontaneous swallow, and cough. You have your main findings, and you can just delineate and use the arrows to decide if they're going to decannulate or not. The results of Mule's study showed that 100 tracheostomy patients with acute neurological diseases participated, and the following protocol tracheostomy tube was successfully removed in 54 of those 100 patients, according to a clinical swallow exam, and 29 would have been decannulated associated with that. The endoscopic protocol provided a safe and efficient and objective bedside tool to guide decannulation. And then finally, education. In-services, brochures, handouts, get creative. Show your team that you are the specialists in this field. All right, we're doing good on time. So now the data, just because I really want to show you guys what we collected. We did a retrospective study from 1/1/2021 to 8/31/2022. And we included all the ICD-10 codes for both percutaneous and open trachs. We had 96 out of 284 patients admitted to trauma. So we only did this on trauma patients and later continued to assess on medical ICU, but then I left the facility so that research stopped. But patients needed to be 18 years or older. They needed to get a trach during that time frame. And then we had a total of 91 participants. What did we look at? All of these measures of interest. Speech consult, did they get one? How many days did it take? Did they get a speaking valve? How many days did it take? Did they get an oral diet? How many days did it take? Did they get downsized or decannulated? And how many days did it take? And then we added a length of stay in there to help with our C-suite and administrative backing because we wanted them to see this data. So this was our mean ages. We had females and males. Our mean participant age was 61.8, and then the post-intervention age was 57. So we're not talking about 80-year-old populations. We're right here in like the middle of the lifespan. The most frequent diagnosis was intracranial injury, which was about 61% pre and 52% post. But we had some other injuries. We had sepsis, skeletal injuries, spinal cord, thoracic, and fractures. Our results are as follows. So the ones that have asterisks or stars next to them are the statistically significant data. So we found using Mann-Whitney and the Pearson chi-squared that we had 4 statistical significant values. It was speech consulted was statistically significant, the days to our speech consult, the use of a speaking valve, and then my favorite one was decannulation was statistically significant, utilizing a speech language pathologist in this team and taking on a lead role. Here are graphs, so you can see the pre is in blue and the red is in post. So there is an overall increase in the frequency and the outcome measures post-intervention. You can see everything is higher than the blue. There was a significant increase in patients who were consulted by speech. There was a significant increase to the days to speech. There was a significant increase in the use of speaking valve and the number of patients decannulated. Why is this clinically relevant? patients being consulted on these patients post-op day one were not lost to rounds, right? They were on our caseload. They were able to return to a normal diet sooner and communicate sooner. We weren't chasing up the team, right? The use of a speaking valve sooner was the ability for effective communication. They can make decisions in their medical process. They can say yes or no. They can participate in their life, what they're going to be doing next. And then the implication to decannulation I thought was huge because that's a big disposition issue. Where can this patient go with a trach? And we get the stares, we get the looks like, oh, here comes speech, ready to like mess up our plan for dispo. But really, do you think the patient's going to want to go to an LTAC? If you can maybe hold off a day or two or just consult me sooner and we can get that trach out, that patient can either go to rehab or home. So our healthcare system is set up in a way that's almost at a disadvantage for patients. And let's get them in and get them out as fast as we can. But I'm still under the impression, and I hope that all of us are, is we want to have a patient leave our facility better than we received them. So why are we rushing to get them out the door? And I've had a note before that said, oh, the patient can get decannulated at a sniff. This isn't our issue. They can do it there. We know it's not happening at the sniff. So that if you let that patient leaves, that patient's going to be stuck with a trach forever. And then guess what? There's going to be a readmission 6, 8, 9 months later to our hospital for a trach dislodgement or an infection. So let's avoid that and try to get them decannulated before they leave. Finally, the trends. I like showing the trends. It's always a downward trend. We had a decrease from speech consults that went from 6 days to 2.5 from phase 0 to phase 3. We had the utilization of a speaking valve went from 11 days to 4. The oral diet return went from 14.5 days to 10. So we went from 2 weeks a little bit down. Downsizing went from 14 days to 11.5. And then the length of stay. This is what got everyone. It went from 32 days to 24 days. So if you calculate how many days that is, I think it's almost 12 days. Is it 12 or a little less than 12 days? That's a lot of money that's saved in that patient being in the ICU or the hospital. So hospitals want to see that. They want to see length of stay and why can this help improve our hospital. Finally, implementing this trach team demonstrated improvements in all of our variables that we assessed, right? We wanted to highlight the multidisciplinary care with a speech pathologist as a driving force, can provide reduced variations in postoperative care, can streamline the process, and improve our patients' outcomes. There's many variations of this team. Go to your facility and pick your key players, but the most important thing is that a speech language pathologist is in there, right? And is contributing based on our experience. And then we really do need future research regarding outcomes. Different patient populations will be really interesting. We're having some literature come out soon with like an ear, nose, and throat population, ENT, head and neck, and pulm. So seeing this in other facilities, like trauma patients, I will say are less sick than a chronic pulmonary or a degenerative disease or a neurological disease. So seeing this literature kind of expand different populations would be excellent. If you have a specific population that you work with, trial it out, see if it works, because I'm just trying to highlight our role and bring more awareness to what we can do for this population. These are my references. And then Brooke said it was okay that I kind of put a plug here. If you guys want to learn more about tracheostomy education, specific to trachs and vents and more management styles, I am providing a lecture on March 22nd. That is specific to that. It's a 2-hour lecture. You'll get professional development hours. You can email me. And then also I have my LinkedIn, my Instagram, and I'm free. I'm available until I pop this child out to answer anyone's questions. So that was it. I hope you guys enjoyed it.
Awesome. Thanks, Rachel. And speaking of children, if you hear my daughter crying in the background, I apologize in advance. We have a lot of questions in the chat, so we'll go ahead and get started on those. So there have been a lot of questions about how this process impacted caseload, specifically what your team did to handle the influx of referrals. Did you add staff? People are asking because, they're concerned that they may have fluctuations in other areas. So could you answer that question for us?
Great question. At my last facility, it didn't really affect productivity or like staffing too much because the volume wasn't huge, right? I was able to take on 99% of the trach patients. Everyone was trained in it. When I was off, other people would see them. But moving to a larger facility, that has been a huge concern. And even my management is like, whoa, do you realize the repercussions? They said it like that, which I don't really agree with. It's not negative. But the repercussions for adding a post-op order set is meaning you're gonna get flooded. Like imagine all the strokes, right? You get all the consults on strokes, and now you're saying, I want all the consults on trachs, you're going to expect a huge influx. It doesn't all happen at once. So I did tell them it's not going to happen the way you think it's going to happen. And they're like, oh, but it might. It really doesn't. I mean, they sprinkle in at the most, and you have a couple extra consoles because not everyone's using the post-op set. So that was a good selling point. They kind of were like, okay, let's trial it and see. We haven't reached a point where it's unmanageable and we can't see the patients, and we're not taking patients aren't getting cut from our list just to see trach patients. It's still like a triage effort. So if we have 72 strokes and 5 new trachs come in, we still have to see our strokes first and use our staffing adequately. We're not saying that these patients have to be seen on post-op day one. Kind of what I reiterate to our intensivists is we really want that consult first up day, but post-op day one, just to know that they're there and we will get to them. It's not an urgency because a lot of them are sedated on fentanyl, propofol. Families just sitting there staring at them. They're on high vent settings. So I would say to combat that question is you may need more staffing far in the future when you really get this up and running and have all your service lines consulting. But in the very baby premature stages of it, the consults come in very slow, and then just kind of reiterate that they're not urgent. They're not like a 24-hour consult that has to be seen like a stroke. Yes, we try to address all our consults in 24 hours, but sometimes they get pushed off to 48 and they're seen the next day. So I hope that helps answer your question.
Awesome. This question, I feel like a lot of people have this situation, so I'm going to go ahead and read this. The SLP said, as you stated, there are many different services who do trach surgeries. How does your team round on all of the trach patients if the placing team is not on your trach team? This is a roadblock I was experiencing.
Yeah, and that's what we're having right now too, is that there's 7 service lines. So our champion is pulmonary, right? We have a pulmonary and like a general surgery pops on from time to time. And this is a different concept from the literature, is that like at my last facility, we were a team that rounded on all the trachs. So whether it was a trauma or a medical ICU trach, the trauma doctors were usually the ones doing everything because they had the autonomy too, to go from room to room, floor to floor, and had that rapport. When you get to these larger facilities, everyone operates in silos. Like ENT wants to deal with theirs, trauma wants to deal with theirs, cardiac wants to deal with theirs. And I get it, and I'm not opposed to it. It's not my favorite thing, but they all practice differently. So what we developed, and this might help you too, is like a management sheet, a tracheostomy manage flow sheet. And it basically did every service line that was traching patients and who to contact. So that's on every nurse station's desk. It's in all of our all of our nursing V drives and our speech drive. So when I get a consult, I see what floor they're on. Maybe it's trauma. And we're having our monthly trach meeting. If we have any complicated case, we don't go over every trach because the volume is just so large. But when I have to go see that patient, I have an issue, I go to my management sheet and I see, okay, this is a trauma trach. The attending I need to contact is this one, or the resident on file is this one. I call that number and I say, hey, this is Rachel from speech. I have a consult for this patient. I'm part of the trach team. We were discussing this case, or I feel like this patient can benefit from a downsize. That has eliminated 99.9% of my chase up because I know I have the correct person on the phone. That's their service line. It's their trach. They've tried to pawn it off before and say, oh, we're not managing it. Refer to the primary team, which at that time was pulmonary. And we're like, no, 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 no. Our new system in this facility is if it's your trach and management is required, we are calling you for a consult to come see your trach. I know that that trach wasn't on your caseload because you signed off, but now I'm calling you because it is your trach and you surgically put it, you're responsible for it. So I don't, it takes a little bit of enforcing, but having a management sheet or a flow sheet of all providers who place trachs, and then you're easily able to follow that and contact them when needed. They don't have to be on your trach team. It's finding a way to easily access them when you're in a large facility. A lot of these studies come out of very small rural hospitals, 300 beds. I think the largest probably I've seen is a 500 bed hospital. And again, that's super small compared to the 800,000 bed hospitals.
This question, I again feel like this is probably a pretty common situation. The SLP said, at our facility, we have a trach team, including SLP and automatic SLP orders, but there are varying levels of RT competence in regards to their understanding of how to do an inline speaking valve and vent weaning. As a result, we often face resistance from them in attempting to cuff deflation and inline speaking valve. Do you have any suggestions or materials to enhance their understanding of the physiological process of speaking valve use?
That is a question we get a lot. I mean, we've had Passy come out to our facility at my last facility and do an in-service. It's usually the older RTs that are very hesitant and they don't like today. The guy told me the rate was too high, I couldn't do it. And I'm like, it's not based on rate. So I think it just requires I don't have any resources, unfortunately, other than like head to the Speaking Valve website and see if you can get someone out there to like do an in-service. As far as like actual literature, in my experience, they don't want to read anything. They want you to tell them. So every day is like a broken record. I don't mind it. I like to educate them, but it's kind of like, let's go and look at the vent together. Like, what is your concern with deflating the cuff? Tell me. And they're going to say, oh, he has too much secretions. Okay, great. We're going to suction before and we're going to suction after. Next, what's your next concern? Oh, the vent settings. Okay, so per this website, and you can give them the passing mirror protocol, it's FiO2, it's PEEP, and it's PIP. So rate is not an issue. The mode is not an issue. Everyone's like, oh, assist control, you can't do it on. So like after I give them that, they're a little bit more receptive. Sometimes they still tell me like no, and I'm like, fine, I'm gonna go talk to the attending and just get clearance. And then they kind of have to at that point because if the attending says I want it, they gotta do it, right? I think it's just more like broken record education, verbal. I like that face-to-face communication with them. It doesn't make them feel like or stepping on their toes because they're still invited in the process. And then they're also hands-on versus like me handing them an article and just walking away. They're not going to read it. So I think the resistance is met with just having a conversation and it being overkilled, like having that same conversation 20 times. And then that one RT that never wanted to do inlines with you becomes like your best friend and does all them. So that's what's worked for me. But there is literature lacking in that department. And I wish there was more respiratory focused leaders in our field that could provide that. Unfortunately, there isn't at this moment, but maybe someone will come out with a course designated to speaking valves specifically for RTs or handouts and guidelines. Right now, there is no standard operating plans for anything related to trach. If you Google intubation, there's standardized protocols for when to intubate. There's nothing for trachs. So it's just this gray area that we work in that there's nothing standardized. So I think this gives us a good opportunity to standardize what we can. Maybe it's up to you to create a flow chart or a guideline of when to use a speaking valve. I have a nice one that shows like how many days patients had a trach, 24, 48 hours, secretion status, vent settings, and it's like a flow chart diagram that I created based on my facility of when we were able to do an inline versus when it was a hard stop. That could be helpful too.
Yeah, I know we won't get to all of the questions, but there have been a lot of questions about where to learn more and resources for SLP team members as well as other team members. So as Rachel mentioned, she does have her Trach Talk business. She also has her badge buddies, which are useful not only for speech pathologists, but also interdisciplinary teams. And she also has provided another free webinar through Dysphagia Cafe. So if you enjoyed this webinar, which will be available on our website within the next couple of days, you can always go back and watch it here, but you can also watch another presentation she did over on Dysphagia Cafe. I think we have time for one last question. And again, I feel like people hear this a lot, so I'll ask this one and then we will close out for the night. But this SLP said, what are your thoughts when a provider or a speech pathologist says we need to wait to see if the patient can swallow before decannulating? For example, someone is NPO with a trach but has been recommended NPO from an SLP and may or may not have an instrumental yet. Do you think an instrumental or diet initiation should be a precursor to decannulation?
No, it should not. And I get this a lot. And I think there was a study that was out recently that I kind of questioned. It was a new study from a company that was saying that they used dysphagia and PO tolerance as a decannulation criteria. And I didn't agree with that because the majority of my patients that we decannulate are not on diets. So if you go back to this slide right here, um, if you look at this, it has nothing to do with PO diet, right? It's looking at secretion, spontaneous swallows, and laryngeal sensitivity. You can have a neural patient that maybe never will eat again in their life, but doesn't mean that they can't be decannulated. You have to think back to why that patient had a trach placed, right? That the etiology of it is huge for me. And I go back in the chart and I find out, was it respiratory failure? Was it head and neck cancer? Was it placed prophylactically? Was there an obstruction? Was it trauma related? That's going to tell you if it can come out or not, right? This patient had a neurological condition. They had a stroke. They had to get a trach because they probably were intubated for a very long time, failed extubation trials, and needed an airway source that could also allow them to be off sedation and be off propofol and fentanyl. And that's why early traching has such a good success rate because they've rid them of this artificial airway in their mouth, moved it to their neck. Patient can now be awake, maybe still is a Ranchos level 3 or 4, emerging, following commands, responding to pain, maybe not verbalizing at all, right? Because you also don't need to talk to have your trach removed. I've heard that, like, oh, they need to be voicing. So if you can use, I think an instrumental is 100% necessary because we don't have x-ray vision. If you don't have fees available, coordinate with an ENT and get that patient scoped immediately and look at their airway because a lot of them do extremely well and you look in there and there's no secretions, there's no swelling. They're not penetrating or aspirating secretions. They're swallowing many times. It says it has to be more than or less than 2 swallows during the 2 minutes, more than 2 swallows during the 2 minutes. Sensitivity, tap it with a little bit of the scope. We're not talking about the fees sensitivity test with the air. We're talking about like if you accidentally scrape the back of the scope on the posterior pharyngeal wall or hit an arytenoid, what is the patient's response? Are they going to immediately adduct? Are they responding? Are they coughing to it? So those are the things that we look at when we look at decannulation. And the studies that I've researched in both of these, PO diet was not an indication, voicing was not an indication. And again, 90% of my trachs that we just decannulate are not on diets. They're just prolongedly intubated patients who needed an airway. Their respiratory issues have resolved. They no longer need that airway. We can work on dysphagia, vital stim, AmCare, all the above after EMST, but there's no reason to send this patient out with a trach that they're no longer needing. They're not needing to breathe from it anymore. The main issue of a trach is respiratory. It's breathing. It has nothing to do with PO diet. So I hope that that's my approach. Some people may differ, and I would offer to hear why they think that, and that's a good question maybe to ask that person why they think they need to be swallowing first. I don't think they're going to be able to give you an answer because there's nothing in my right mind that can think of why that should be a precursor, right? Like they just don't correlate to me. One is breathing and one is swallowing. They're two different facets. You can breathe without swallowing, you can swallow without, you know what I mean? So I wonder what their response would be. That would be my answer. Yeah.
Awesome. Thanks, Rachel. So there was a couple of questions again about CEUs. We forgot, or I forgot to mention, I think Passy Mirror, and someone put that in the chat. So if you haven't already, check out Passy Mirror. They have a ton of free CE courses, which are wonderful. And then someone else asked about secretion management and the use of fees to assess this patient population. And as Rachel mentioned, her mentor is Dr. Eric Blicker, and he has a lot of wonderful courses, both in person and online. So if you haven't already, be sure and check that out. And with that, we'll go ahead and close out for the night. Thank you all so much for being with us this evening. Thank you, Rachel, for being with us, even though you're not feeling the best. If you all have any questions, feel free to send me an email at tims-univ@tims.com. Thank you all very much.
My email's
Bye.
there too. You guys can email me as well, okay? Thank you so much.
Awesome. Bye, Rachel.
Bye.